Hello, welcome to Adapt NCLEX. Today I wanted to do something about pulmonary embolism, focusing on clot, and that means DVT embolism, and septic embolism, and fat embolism. Then talk about some DVT and AFib. So let's get to it. What is pulmonary embolism? Well, pulmonary embolism is very important because this is an airway and breathing issue that you encounter. So it's basically some foreign body, I'll call it, has get into your lungs and preventing your lungs from doing its normal function. So there's ventilation and perfusion mismatch. The air is coming in, but it's not getting the oxygen from the venous supply, the arterial supply from the right side of the heart. So that's what is going to happen. There's a bunch of things that can do that. The problem can be clot from your lower extremities. It can be air embolism from catheter. It can be fat embolism from tissue breakdown. Usually the tissue, what I mean is if you have a fracture, long bone fracture, the fat globuli usually get embolized and go into your lung. Embolism means moving from where it was initially and going to a different place. It can be bacteria. So bacteria also can do that. That's when you have septic embolism. Even tumor cells can embolize into your lung. And so these are what can get into your lung and prevent the normal function of your lung. What to know about is how do they present is the most important. This is an emergency. This is a priority patient. Give you who do you see with the patient with the pulmonary embolism, you need to see them. How would they present as a nurse? It's an acute onset. So acute onset, and then they may have cough. Okay, the cough can be productive or unproductive. Unproductive. So, and then the most typical one they have is chest pain when they take breath with inhalation. So when they take breath, they have chest pain. And then you expect them because there's lack of perfusion, ventilation mismatch, what is going to happen when they become hypoxemia, they become hypoxemia and they become tachypnea. They start showing you the signs of respiratory distress, okay? And this is very acute onset. I mean, and you expect them to be, they have dyspnea. All these things is a long problem. Something telling the patient that they're not doing well in terms of their respiratory wise. Sometimes they don't show this, but in who do you see, they'll tell you a patient all of a sudden is restless. Keywords. Look at my B sharp. And then the anxious or anxiety. These are the one they try to trick you. If they give you hypoxemia, tachypnea, or dyspnea, and chest pain, you get it. But they will give you like restlessness, anxiety. Those are your clue that, oh, something is not good. They can have low-grade fever. So that is not usually that diagnostic, so low-grade fever. But just let you know, in case they give you a patient with PE and then pulmonary embolism and you see low-grade fever, don't be surprised. The problem with this is if you don't do anything about it, right heart, okay, right heart strain. So the heart, you go into like a heart failure on the right side because all the blood cannot get into the pulmonary system to be oxygenated. So the blood stay in the right side of the heart. And they have right heart strain and it become a problem. So in a diagram form, you have something like that. Okay. So this is our pulmonary system, no, our cardiovascular system. So this is the right heart, right side of the heart. So right atrium, right ventricle, left atrium, and left ventricle. and the lung will be sitting here like that. Okay, blood from the deoxygenated blood from the right atrium go into the right ventricle, then they go here to be oxygenated. Now you're having all these deoxygenated blood sitting here. It cannot go into the lungs, and therefore you put a strain on the heart, and mostly right side. So if they're going to have any problem, it will be the right-sided failure. If you don't do anything, they're going to have cardiac arrest because now they're not getting any oxygen at all. So this is the briefly, this is what happened. So what do you do as a nurse? Well, treatment is what? The first thing you do is assessment. So they will present with acute onset of shortness of breath, restlessness, anxiety, fever, low-grade fever, chest pain with inhalation. So you got to figure out what is the problem. Okay, you got to figure out what is the problem. So you assess them. After you assess them, you see all these things. Just give them oxygen. So give them oxygen and let the ACP know about it. You cannot just call the ACP. You can do something, assess the patient and figure out what is the problem, provide some oxygen support, and then let the doctor take care of them. So this is briefly pulmonary embolism. Remember, this can be anything. It can be a clot. Okay, it can be clot. It can be air, it can be fat, it can be bacteria, and it can be tumor. So any of this can cause that problem. And so this is the summary of that. Now, we can talk about the fat embolism. Now we're taking each one of them and see what we can do about it and just learn about it a little bit. So usually it happens with the long bone fracture. So let me draw it and you will see. So you have somebody at a femur fracture, big. So this is the femur, okay. And this is the long bone. So this is like the femur fracture. Okay, they will have this femur fracture. And then all of a sudden, okay, all of a sudden, they have acute onset. This one too is an acute onset. You have acute onset of respiratory distress. Okay. All of a sudden, they will be confused. And then they will have this petechia on their skin. This is the hallmark of fat embolism. Usually look purple, pink on their skin. And so that's what your clue. They won't tell you, but it says somebody had a fracture of his femur. It was one day later, all of a sudden, acute onset of respiratory distress, shortness. What I mean, shortness of breath, desaturation, tachypnea, pruritic chest pain. Then they will see petechia on their skin, and then confusion. Why is this happening? Well, the long bone, you know, bone, what is made up of bone is fat. Okay, it has some fat in the marrow. The marrow cells, mostly fat. And these get exposed when you have bone fracture, long bone fracture. And these plus platelet, it get released into the blood, and then they bind with platelet, and they form the embolism. This becomes the fat. No, they become the fat embolism. And they travel into your blood system and go to the right side of the heart. Okay, and then to your lungs, and you go to your lung, and that become the problem. And then it does the same thing like the any emboli that would do that. But then the symptoms that they have is the fat emboli go to the skin. That's why they have petechia. Okay, it goes to the brain. The brain is where they have the confusion and acute change in mental status, and then it goes to your lung. Okay, that's why this is what gives them this is the initial what we worry about most of the time. Okay, so This is the respiratory system. This is what you have over there. So that is the presentation, and that's how. So you have to, like I said, they will not tell you that, but you have to have high suspicion, okay? High suspicion with this disease. You have to be suspicious. Long bone fracture, all of a sudden having these symptoms, you have to worry about fat embolism. Treatment usually supportive, so you support their airway. You cannot go and take the fat, but you can prevent it, okay? You can prevent that problem. How can you prevent it? Well, number one thing you should do is minimize manipulation of the fraction. Okay, that's why you don't move. If they have a femur fracture, we try to splint it as much as possible. That's why they splint. So too much movement will release the fat into the bloodstream, and it go into the lung and then embolized to the rest of the body, and it become a problem. So we try to minimize the fracture until repair, okay, until repair is done. So as a nurse, if you see your UAP moving a long bone fracture that is not being repaired, you will say, no, 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 don't do that. Don't do that. It's not allowed. Okay, and that is briefly, that's all. I think this is usually who do you see first. It will be a who do you see first, but you have to have high suspicion about bone, where it is bone or trauma, and what kind of bone fracture is long bone, okay? Like a femur usually is the place which is the long bone, okay? And then you'll be able to make the diagnosis and pick that patient. It's still pulmonary embolism, but the source is fat, bloodline. Okay, good. Now we go to the D vein and thrombosis. So DVT. So what happened? Well, your veins in your legs, they have valves, okay? They are valves that you control blood to go in one direction. Blood can go in one direction. So blood in your leg, that goes to your leg, need to go back to the heart. So it has to go in one direction. Sometimes you have reflux and blood stay there for a long time and it can form clots. Or sometimes you don't, when this valve goes in this direction, they reflux, we call it reflux. And they allow blood to stay here, and then you can form a clot. And this is what's called varicose vein. Varicose vein. So it depends on what kind of situation you have. In any case, you form a clot. What are the risk factors of clot formation? And that's what you have to know. What are the risk factors? Is stasis. That means you don't moving. Anything that prevents immobilization. The example is you long travel, okay? Long travel. Or you have a long flight, okay? Patient has been admitted in the hospital for like 5 days, no movement. Or prolonged standing, okay? Prolonged standing. If you stand on your feet for a long time, blood pool, and it causes the problem. So that's number one. Anything you can think of, like bed rest. The second one is, we call it hypercoagulable state. That means you likely to form clot no matter what. And the number one is factor 5 Leiden. This is defective gene that involved in clotting or inherit. But there is other thing that will put you in hypercoagulable state if you take oral contraception. Remember, in your test, the oral contraception that is at risk for forming clot is those that has estrogen in it. Progesterone ones don't do that. So pay attention. Don't pick an answer So when they give you which of the following patients are risks of DVT or SATA question, and they just give you she's on only progesterone alone, well, they don't have risks. Their risks of DVT is very low, really, really low. It's those ones that have estrogen in it that can be a problem. Or pregnancy, okay? When you're pregnant, you are in a hypercoagulable state, so you're likely to form clots. And the last one is trauma, okay? So anything that can cause endothelial injury inside vessels itself. And what are those? Like if you had surgery, they destroy the vessels and it's a form of injury to the endothelium, okay? And that can cause damage to the vessel and then you form a clot. These three, we call it, there's a name for it. It's a Virchow triad. You don't need to know. I just put it there for you so that you can remember. Virchow triad is stasis. That means you're not moving. You are in a hypercoagulable state or you have trauma. And these DVT can embolize into the lung and they become pulmonary embolism. Okay, so that's the way. So somebody will ask you in signs and symptoms, okay? Signs and symptoms. I keep on saying signs and symptoms, okay? Signs and symptoms. This is your SATA right there. I'm going to list them. And if you know all of these things, if you know this presentation, if they give you any patient with SATA question on DVT, it's straightforward. And I'm going to use the pathophysiology based on what I have. And you have clots sitting here. And we're going to just list them based on what we think it should be. Okay, so if you have clots sitting in the vein, well, your leg is going to get warm. Okay, it's going to get warm. If blood stay there for a long time, there will be erythema. Okay, like bruises over there, and it's going to get warm. This usually they have pains. If blood stayed there for, this is the same thing. If you look at my video on peripheral vascular disease and venous disease, it's the same symptoms like varicose vein. They will have calf pain, okay, calf pain. Sometimes they won't describe it calf pain. They will describe it door pain. One of the calf will be greater than the other, so unequal calf. So that's your clue right there, okay? Because the blood is sitting there for a long time and then they have erythema, that means you can assume as if there's too much fluid over there. So they will have edema, like the venous patient who have varicose vein. The same thing, they will have edema. But remember, edema is unilateral. I've never seen, after practicing for a long time, I've done surgeries on people. I've never seen anybody have bilateral DVT. They can have bilateral pulmonary embolism. That means the clot went to both sides of the lung, but to have two clots in your leg is unlikely. I've never seen that before. So you only have one side, one calf bigger than the other, calf pain and the edema and all these things are carrying only one side, okay? And then they can also have low-grade fever, so don't forget about it. So that's your SATA symptoms right away. If you see a question like that, somebody with DVT, calf pain after surgery, these are what you see it for you to make the diagnosis of that. What is the treatment? So the treatment is anticoagulation. Okay, we got to give them something to prevent the clot formation. So we give them anticoagulation, so treatment. So they get anticoagulation so that the blood become thin now. It doesn't clot. Of course, if you look at my lectures on pharmacology, there's a bunch of them. We can give them heparin. You can give them warfarin. You can list them. You can give them the gatrobans. That's their last name. You can look at it. But you see the name, something with the gatroban at the end. Okay, and like Rivorapasan. There's a bunch of them, but You don't need to know the name, be able to recognize their last name. This one they like, which I will list it as that. I think about it. I think I should write that one. Enoxaparin. That's Lovenox, which is a lower molecular heparin. So that one, but the Gatrobans and the Episibams, there's a bunch of them. And the Paroxin, they have different. There's another ones that has last name of Parinx. They are the same. Those are anticoagulation. This is what you need to know. Sometimes they ask this to trick you. These anticoagulation is to stabilize the clot. They don't burst the clot. No bursting of the clot. Okay. They stabilize it and they prevent new clot formation. Basically, they stabilize the clot so that your body fibrinotic system can come and break these clots. Okay, and they prevent new one from forming. So that's their main function. So this is the pharmacological aspect of it. This is the question they can ask you whether you know it or not. Anticoagulation don't dissolve it. These particular ones, unless they are thrombolytic, but these are not thrombolytic, they are anticoagulation. So based on their name, they shouldn't lytic the clot. They shouldn't break the clot. They will stabilize it, but they will prevent new formation because they are anticoagulation, new formation of clot. They prevent you from forming new clot, not old, dissolving the old one. Okay, so that's your treatment. You just prevent them from having more clot. Okay, then you got to teach them how to prevent it. So you still have to teach them how to prevent it. So there's certain things you can do in a hospital to prevent clot formation. Okay, early ambulation. Anybody who come in the hospital, get admitted, keep them walking, make them busy, keep them walking, okay? And then put SEDs on, compression device to push the vein out. If they're going to be bedridden for 5 days, then you know. So these are all clinical things I try to teach as if you are applying. It's not for just the exams alone. It's for you. Clinical knowledge is very important. If you have good pathophysiology, it will have your clinical knowledge, and then your critical thinking and your practice. So the same thing. Keep the vein out of the leg. Okay, and then that will help with that. And then they will need, if this medication, so heparin sub-Q, this is a prophylaxis to prevent. So this is what we give patients to prevent clot formation. If we know that they're going to be in a hospital for a long time, we give them this to prevent that. We are, and this is like 5,000 units. They get a 5,000 unit heparin sub-Q, no drip. Okay, remember you don't check PTT on that. Or they get Lovenox, which is enoxaparin. This is like 40 milligrams sub-Q also. So they get this every, and the Lovenox enoxaparin is usually once a day. So it's once a day. This is daily. But this one is every 8 hours. So Q 8 hours. So they get it 3 times a day. So that's what you do. The other thing I need you to know is if you see a patient with DVT, okay, they can ask you. Now they already have a DVT. You're giving them the anticoagulation to prevent new formation. Do not massage the leg. Because of the edema, you'll be tempted to do that. If you see a UAP doing that, tell them, no, that's something you have to intervene. Don't do, double negative. Do not massage, okay? They can walk. Walking is okay. So people, it used to be that somebody have DVT and they put them in bed and they make the thing worse. You don't work till 5 days. Well, they get more clot and they have more PE. So walking, again, walking is okay. Walking is okay. But you should not massage that leg. If you massage it, then the clot will embolize and it cause problem. So you got to teach them not to do that. Then you got to teach your team that you have how to take care of this. This one is a testable this thing because it's very important in terms of fundamentals. So delegation, what do you do with this? Okay, delegation. The RN is what does the RN does? They eat all the time. What does that mean? That means initial evaluation, assessment, initial assessment, and teaching. Therefore, your job, this is how I remember delegation. Nurse eat all the time. Evaluation, they eat first. How about that? The nurse is supposed to eat first. Evaluation, assessment, and teaching. And so because of that, you, the nurse, will assess the patient. Okay, this patient first for DVT. So you are responsible. So in the delegation question and say, who did the assessment for the DVT is you. And you do the plan of care. Okay, you have to do the plan of care. So nobody does that for you. And you provide the teaching, all the teaching I've told you, and evaluation. So you provide that for the patient. You provide the teaching and the evaluation for the patient. Then what you can do is delegate. So you can delegation. Now you can delegate delegation. The LPN, what can the LPN do? Well, I have an acronym. I call it MMR most. MMR most. So the first M is monitoring, okay, your observation. The other M is, and they can give most medication, okay. The R is reinforcement of your teaching, okay. Then the M again, monitoring your observation. And then they do O is ostomy care. So any gastrostomy, colostomy, ileostomy, and the T is tube feeds, and the S is special test. So they can do bowel sounds, they can do neurovascular check, they can do lung sound. So based on that, you know that the LPN, what they will do is they can give the anticoagulation. So they can give the anticoagulation medication. You can let them do that. They will be able to do that. The Lovenox and other things. And then they can they can also reinforce your teaching. Okay, they can reinforce your teaching, and then the reinforcement, what you already taught the patient, they can reinforce that. So they can give the medication, reinforce the teaching, and then they can apply. If you have to give compression device, they can apply and measure the patient for that. Remember, compression device is not, you cannot just pick any compression device. Okay, they have to be measured and then apply and put it on. So they can apply the compression and they can do the measurement too. Because of that, what does the RN do in terms of the compression device? Well, you have to provide the teaching of all the teaching that involved. The LPN can do that. So you tell the patient this teaching is coming from you. LPN can reinforce it. So in terms of the application of the device itself, the LPN can do that. They can measure and do that. When But when you have to teach the patient how to do it, you will do that. And after you've done that, then they can enforce that. So how do they do that? They should not, do not roll it down. They shouldn't roll the device, the compression device down. When you put it on, it's like a sauce. You come all the way and keep it flat. No wrinkles. Okay. They should not roll the top down, no wrinkles. They shouldn't alter it. If it's too long, don't alter it. You know, they shouldn't know that. These are all done. No wrinkles, no alteration at all. You shouldn't, they should not fold it down, don't fold it. And then they have to put it on before they get out of bed. Out of bed. So out of bed. So they have to do that, put it on before out of bed. And this is something they can ask you in the SATA question. How do you apply compression dressing? Well, they put the whole thing up and they do not roll it down. They make sure there's no wrinkle. They should not cut it. They should not fold it. They should apply it before they get out of bed. And the other thing some people forget is the toe opening. Okay, the toe, there's a small toe opening of all of them. And it's very confusing. Where does it go? You go on the plantar side. Okay, plantar side of the leg. So the plantar side is under your foot. So this is the teaching you provide. And then once again, the LPN can reinforce it. We can reinforce this teaching. So they're about to go home. They have DVT. Now teaching at discharge, okay? They're about to go home. What do? You got to teach them how to prevent it. You see how small thing, they can ask you so many questions. The examiners can ask you, it's real life, you applying it. So you got to teach them how to prevent future DVT. Well, they should elevate their leg, okay? Elevate legs when they're sitting down, make sure they're moving it, okay? Keep on moving legs. They should do that. They shouldn't cross, no crossing, okay? No crossing of your leg. And avoid long trips, okay? If you have to stop on the way, just stop, walk a little bit, and then continue the journey. So you go for like 3 hours, you drive, then you stop, you continue again. Long flight, avoid it. But if you can, well, tell the flight attendant, please, I'll be getting up more often. So you have to go to the bathroom if you don't have to go. So get up more often, okay? But you have to tell them and warn them. And the other thing, you can even be sitting down and moving you exercising your calf, okay? You can do that, and then that will also help and prevention, and that is what we call dorsiflexion. So your dorsal aspect is towards you, okay? The plantar is on your feet under, so you flex it up towards the leg. And so dorsiflexion of the foot, it just basically push the blood up. Okay, all these things is very important to prevent DVT. And let them walk. Okay, walking, you can enter into walking program. You can go into like a dancing program, you know. This is to keep you physically active, exercise. So exercise is good. This is our teaching. You have to think about it. It just came into my head. I'm just listing them. The other thing too is blood clot. Sometimes if it's too viscous, okay. So hydration, I think, is good. So usually in your test, when they say hydration, it means 2 to 3 liters a day. If they give you constipation patient and you're talking about hydration, they have to drink 2 to 3 liters a day. So hydration is very important. And this is your SATA right there, teaching after teaching at DC. Okay, before discharge, this is what you teach them to prevent blood clot in the future. Okay, prevent blood clot in the future, and that's very, very important for the nurse and the patient together. Now, we are on the bacteria. So like I told you, is anything, DVT is very interesting. Pulmonary embolism, anything can cause that. So that can get into your lung. The bacteria one is usually you have central venous line for a long time that get infected. That's why we try to remove them when we don't need it. So no central venous line if not needed. And you just remove it as soon as possible. They can get infected. When they get infected, you have the bacteria get into the blood, so bacteremia, and then it go into your heart. Okay, which side of your heart? This one you have to know. It go mostly on the right side first, and then it stay on this valve, the tricuspid valve, and that is the most common site of bacterial emboli, and it stay on the valve, and the patient will develop endocarditis. These bacteria can then embolize into your lung, so embolized into lung, and cause problem. You do the same thing. They were going to have the same symptoms as anybody who has either the clot causing the problem or fat causing the problem. The issue with this is very classic. So you can watch my endocarditis video. Is very classic. It go everywhere in your body because now it can travel everywhere. You go into your brain, okay? You go into your skin, you go into your leg, you go into your eyes. You can also, any organ, okay? Any organ in your body can get this. And they say, and that's the embolize. Your lung, when you get into your lung, then you get embolism, pulmonary issues. But the other ones, and I just want to add this in case you have not watched my lecture on embolism, endocarditis, cardiac infection. This specifically, the bacteria, because it goes everywhere, there's a way you can remember it for endocarditis. That means infection of the inner lining of your heart. Okay, so I call it Jane from Jane. Okay, that's how you can from Jane. And what does that mean? From means they have fever. Okay, they have fever. The infection. R, the emboli go into their eyes. They have red spots. Okay, so these are on the retina. So this is their eyes. So retina. Then the O is, they call it the Oslo nodules. And that's if you look in on the tip of their finger or their toe, you see some redness there. It's a spot, okay, toe. That's the Oslo nodes. Then because it's affecting the tricuspid valve, they will have a murmur in your heart. You can hear it. And Jane, of course, Jane brought you some bacteria, and is Janeway lesions. And this is almost the same as the Oslo, but they occur on the palm side, the palm and so. You see spots over there. It's called Janeway. And the A is they're usually anemic. And the N is, you see the emboli, it get into their nail, okay? They get the fingernail. And then in your test, they will put splinter hemorrhage. That's what it is. When you hear splinter hemorrhage, that's what it is. So it's on the nail bed. And then the E is embolized to any organ. So embolism, and so your lung can also be involved. It can go into your spleen, everywhere. So that's endocarditis. Your treatment is long-term antibiotic. You remove the catheter, and then you treat them with antibiotic for like six weeks. More, there's a risk of recurrence. So embolism from bacteria can occur into your lung, and you have the same symptoms as other conditions. Now, this is my favorite, and this is clinically, you as a nurse, you should know this. It's very, very important. This is air from IV, central venous line, which is bad. Okay, we put IV in. That's why I don't like central venous line. I hate it. There's so many complications, but we need it. You can get at least between 90 to 100 ml of this thing per second. If you open the IV, that's how much air can go in. Your body doesn't like that. It happens all the time. Every time you put the IV in, there's a little bit of air that go into the venous system. It can get into your body take care of it. But sometimes there's too much in a very short time. And that is what we call the air embolism. You go into your lung, okay, lung, and this is deadly, okay, life-threatening, okay, emergency. You have to do something. You have to be sharp. It's an airway problem. This is where you don't have time. So when they give you four patients, who do you see first? And you see signs of embolism, choose that one. Don't leave that one go away. And so it usually happens. So presentation, let me make something up. So presentation. So you pull in IV all of a sudden. So pulling IV from a patient. All of a sudden you hear the kissing sound or easing sound. So you hear easing sound or a rush of air, very rush of air. You can hear it. All of a sudden, that's a problem. And then the patient will develop respiratory distress right away. That's your clue. You pull in IV, so that's what the question would be. There's no way they can answer this question differently. That's your clue that something is happening. So what does that mean? They will become hypoxemia. They will have dyspnea. They will feel like they're dying. So it's like impending doom, okay? Impending doom. They feel like they're doomed. Something like bad is coming. They are about to, something is wrong all of a sudden. They will be restless, The same symptoms you can see on my B chart. Something is not right with them. Their eyes, they will be telling you, they look like death. We call it dead stare, okay? Somebody is staring at you like they're about to die, that's your sign. Pulling IV, rush of air, and a dead stare. Rush of air, easing sound, feeling of dying. That's your clue right there. So what do you do? This is a priority. So you, the nurse, you have to do something right away. Right away. Intervention, I'll put it here. Intervention. Nurse, what do you do right away? Nurse intervention. The first thing you do is to clamp above where the IV is, right there. If you have a tourniquet, IV side. If you have a tourniquet, just clamp. Usually you can do at the bicep, just way above it. You tight it quickly, okay? And then you clamp just above the IV line. So you can do two, or you can just clamp up just above the IV line. I like to clamp twice. Them on the left side. Left side. Put the patient on the left side and their head down. So Trendelenburg. So I know how they can trick you. We call it, the word is Trendelenburg. Okay, so left-sided Trendelenburg position. So their left is side, so you put it on the left side, and then you put your head down. These allow the air to rise up because the air is going to their heart first, and usually go to the right side, so the right heart, before you get into their lung. And when you do that, the air stay in the right atrium. So it stay in the right atrium. It doesn't go. It doesn't go. It doesn't go into the lung. So it stay there, and later on it get absorbed slowly out of the system. So this is why these two steps is very important. Clamping whatever site you want to clamp, okay, but not below the site of insertion. Clamp it, put them on the left side, head down, and this gives you some time, okay? Don't call the doctor at this time. You still have something to do as a nurse. You hire a provider, so provide some assistance for the patient, save the patient life, okay? So put an occlusive, I'll put an occlusive dressing at the side so that no more air is going into the vein, no more. This is the time you give them oxygen. Remember, you already put, when you put the occlusive dressing, you put the line out, okay? Just put the line out. Most of the time, the line is already out because you initially when trying to put the line. So the line is already out, and that's when they start having these symptoms. So occlusive dressing, give them oxygen. And then the oxygen too, it has to be a non-rebreather. You can't give them nasal cannula, and they need 100%, a bunch of oxygen. Then you call the doctor, who probably in the cafeteria, and then he will not answer the phone probably, but that's what happened. If you're lucky, he gets you on the phone. And somebody have to call, okay? So this is somebody, not you. But you call, you find, you press the call bell and you tell the secretary, can you call Dr. So-and-so to come to bedside? Yes. But you stay with the patient because they feel like they're about to die. You stay with the patient and you monitor them. I mean, maybe keep on checking their vitals and keep them. So you have to know this. These steps, you have to know this, how they present. And because this will be a SATA question, this will be a diagnosis question, and then prevention question. When you're studying, I keep on saying it, keep on going through the steps. Okay, hair embolism. What do I need to know for the test? What is more critical? How to take care of it when it happens. Then the first thing, I need to know how to diagnose it. Now we got to prevent it, okay? Prevention is also very important. So to prevent it, we have to learn certain things as a nurse to prevent it from happening, okay? Don't put central line in if you don't need it. If you stay there for a lot, if you don't put it in if we don't need central line in it, okay? But if it's there, most of the time, this happens when it's being removed. Removal is the episode. So removal of line. This is when it happens. It happens when you're trying to remove the line. Okay, so just be careful. So this is what they do. The first thing you tell when you pull in a central line out of the patient, tell them to be supine. You keep them supine. Head no up, down, nothing. Flat on the table. This improves your venous resistance, and more blood is in your venous system such that it prevents the air from going into your lung. That's why they have to be supine, flat on the table, okay? Then exhale. No inhale completely. If they inhale, they're sucking the air into into the venous system, to their heart, and to their lungs. So they have to exhale when you pull in it, okay? And then I usually cover the IV side with occlusive dressing, okay? So you have occlusive gauze on it, okay? They lay in flat, tell them in exhale, put the gauze on the IV, and then you can pull it. You pull it slowly, okay? You pull it slowly, but continuous, okay? Continuous flow. Pull it slowly, continuous, no fast. If we put it too fast, pull it too fast, it can break. So pull it slowly, but continuously. Resistance, we need to stop, otherwise it will break. When it breaks, it's not easy to take it out. It can embolize into the lung. That one is bagged. The whole catheter now, the catheter has embolized, not just a embolism. So you pull and pull slowly, but you can, if you feel any resistance, you stop. Then when you're done, the last thing you do is occlusive dressing. So occlusive dressing. And that's like, I don't know, it's something like Tegoden or any plastic, something that will, any occlusive dressing the hospital have, you just put it on it. And then you take care of the patient. And that is the way to prevent it. Okay. Sometimes this is what happens. They may trick you. They will give you a patient, but they won't tell you this is the problem. You have a patient, okay? All of a sudden, his central line or PICC line, okay, PICC line or central line has lengthened. So the length is longer now. This is why when you have a central line, a PICC line, the priority action for this is look at it, where is it on the skin? Some of them have numbers on it. So you look at it, oh, this is how far. You measure it every day. Say, oh, it's 2 centimeters or 5 centimeters from insertion site. Okay. If you come back one day or lunch, you went to lunch, you come back, it's 8 centimeters. Well, your priority function, your test is all priority. Okay, don't just flush it. Don't just try to push it in. No, that's not the priority action. The central line has lengthened. The first thing you do, you stop all infusion. Okay, stop infusion through the line and get a chest X-ray. Chest X-ray will tell you which part, whether it's still in the is in the central venous system. Most of them go into your right, into the heart, so the right atrium. You just sit there, not all the way. You just sit in the superior vena cava, and then right close to the heart, basically, but it doesn't go all the way into the ventricle. So it just sits right there so that it doesn't irritate the heart that much. And so you just look and see, where is this line? If it's not in the right place, then you pull it. You don't push it in again. So it's very important. And that's what this applies to this is what causes the emboli and other thing. Any lengthening of the central line is a priority patient. You should see that patient first to manage them, to prevent further embolism. And so the last one I want to talk about is AFib. Okay, so AFib, what is that? It's related to that. So atrial fibrillation. So people develop abnormal rhythm of the heart. It's a form of abnormal rhythm of the heart that is not working is supposed to. The signal, the SA node and atrioventricular node is not functioning the way it's supposed to. So you have irregular, check my cardiology EKG lecture on that. They have irregular rhythm. So the rhythm is not the same, okay? The rhythm is not the same. It's not the same, it's not regular. So you have irregular rhythm, okay? Irregular rhythm. These ones, you don't have a P wave. You can't find the P wave, but the QRS is normal. The QRS is normal. The RR interval, okay? The RR interval is off. And that's the main problem. Why is this related to that? Well, because of the turbulent flow in the atria, they can develop clots, and this can go embolize the places. Most of the time, not to the lung, because it's on the right side. If it is on the left side, so if you go to the left side, it has to come out of the system and go all the way, come back to the vein into your lung. So it doesn't cause pulmonary embolism. So don't get fooled about that. AFib doesn't cause pulmonary embolism. All it causes is stroke. Sorry, the clot will go into your brain. Okay, it can go into your legs. It can go into your intestines, and it can cause ischemia. So this is why people, AFib people causes they have strokes, ischemia of the leg and the abdomen. So you can have ischemic mesenteric ischemia or ischemic colitis. The problem is they will need anticoagulation. They too need anticoagulation. But why? To prevent clot formation. They prevent clot formation because of the turbulent flow. Just a few knowledge check. When somebody has AFib, priority action is what? Number one priority action, rate control. Control their rate. Anticoagulation is there to trick you. It's not important. This is later on. So acute onset of AFib, new onset of AFib need rate control. Don't choose an answer because it's AFib. They give you EKG and they say, what do you see? This is a AFib. You diagnose it because it's irregular and then you choose anticoagulation. No, you should choose the treatment is rate control. You want to slow down the heart. So slow down the heart. So you can use anything you want, anything that can slow down the heart. So beta blocker, you can use the digoxin and digoxin, okay? You can use what other medications slow down a calcium channel blocker. Anything you can think of that can slow down the heart is what we use for AFib. So slow down the heart. That's all. Then later on, you get echocardiogram, then you put them on anticoagulation. So don't about somebody with the AFib, giving them anticoagulation is not the best way. Is providing them with rate control is always number one, rather than giving them anticoagulation. Okay. Now, treatment, just a brief treatment in case you have not watched my video on the EKG. The treatment for AFib is rate control. But the rate control, what does that mean? See if the patient is stable. You have to know if the patient is stable versus unstable. That's number one. Every time when you have tachyarrhythmia, is the patient stable or unstable? If they're stable, yeah, you have time. You can give them an anticoagulation. You can control their rate control. So you can choose any of this to control their rate. If they are unstable, that's where the examiner likes. If the patient is unstable, what do? Unstable, AFib. And what does that mean to be unstable? They are dizzy, so dizziness, shortness of breath, not even shortness of breath. I think confusion, that's changing mental status, hypotension, the blood pressure is low. So these are all telling you they're sweaty, okay, diaphoretic. They don't look good, okay? That's not look good. If you see that, what do? Is cardioversion. What kind of cardioversion? Synchronize. Cardioversion. To synchronize cardioversion. And please, 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 please turn on the sync mode on the AED or the defibrillator. If you don't do that, you kill the patient. So turn on the monitor to a sync mode, because most of the time the AED or the crash card is on the defibrillating mode. So if you take it and you shock this patient with that, you kill them because they are not in a shockable rhythm. So you have to cardiovert them, and it has to be synchronized cardioversion. one more few things before I go. Things are coming to my brain. This procedure is elective. So it's elective. They need consent. Okay. You tell them that their heart is going to stop. You want them, and they need some sedation. So like Valium to calm them down, and then you do the procedure. And the energy they use is usually low, like 50 to 200 joules. So that's your SATAT right there for synchronized cardioversion. Sync mode is on. It's an elective procedure. Consent. Tell them about the procedure. Heart is going to stop. Sedation, Valium, and then the joules that you use is that. So basically, this is everything about what I plan to. I think I can go with this. I know there's a lot of information, but I just focus on the most important things you need to know for your exams. Once again, thank you for listening, and check my YouTube website and Facebook for more videos, especially YouTube. Subscribe and keep charging. Good luck in your exams.